I'd like to invite Dr. Haukos to join me and also invite the next presenter on the next abstract session. So this is Dr. Jeremy Chan.
Good to see you.
See you. Dr. Jeremy Chan talking about large national variation in the use of multiple arterial grafting in isolated coronary artery bypass grafting in the United Kingdom. Thank you.
Thank you once again for the opportunity to present the work here. I have no disclosure. There has been a reduction in the use of multiple arterial grafting in the United Kingdom and also worldwide. Less than approximately 10% of all isolated coronary artery bypass grafting in the United Kingdom was performed using 2 or more arterial graft. But why is that? Is it because the patients are getting worse in terms of preoperative characteristics? Is it because of surgeons, or is it because of hospital? In order to look at this, we adopt a multi-level modeling, which is a very fancy logistic regression model. I'm not a statistician myself, but to make it very simple, this is a tool that has been developed to look at the variation in the school performance in the UK. So we have candidate, teacher, classroom, and school, and so on, so on. So you can then detect where the variation is from. We then apply this multi-level modeling into looking at multi-arterial grafting. We have included approximately, again, 130,000 patients from 2010 to 2019 in the UK. And exclusion criteria is similar: previous cardiac surgery, concomitant surgery, or emergency or salvage procedures. So they're all isolated, elective, or urgent coverage. We then applied the multi-level modeling into patient factor, surgeon and hospital from level 1, level 2, and level 3. We then looked at whether the variation is from patient characteristics, Euroscore 2 variables, socioeconomic status. We then look at surgeon-specific factor, whether the surgeon volume plays a role, and whether the surgeon be able to offer off-pump coronary artery bypass grafting will have an effect on multi-arterial grafting. And last but not least, hospital volume divided into 4 quartiles. The overall multi-arterial grafting rate in the UK was 11% from 2010 to 2019. The variation was 30% from surgeon, 20% from hospital level, and 49% from patients. And some of the factors associating with the use of multi-arterial grafting: younger patients, male patients, better left ventricular function, non-diabetic patients, basically better patients in a non-urgent setting, and better socioeconomic status. Surgeons able to perform off-pump tends to offer or had a statistically significant association to offer multi-arterial grafting, while surgeon volume and hospital volume does not, in terms of statistics, have an effect on multi-arterial grafting use. But regardless, our results demonstrate a large variation in the use of multiple arterial grafting, and only half of the variation is because of the patient. 30% was because of surgeon, and 20% was because of the hospital. Thank you.
Thank you. Are there any questions from the floor? Did you find any regional variations in your analysis?
To avoid going to a lot of politics, the answer is yes, there's a lot of regional variation. There are centers who offer, surgeons who offer off-pump multi-arterial grafting for nearly most of their cases, while there are membrane Juve non-pump surgeons for their whole career. So there are regional variation and surgeon variation.
And I don't know whether you were able to, but you wouldn't have that data, but it'd be interesting to see the experience or the length of time that the surgeon had been a consultant for. So were the more experienced surgeons offering more off-pump surgery, and the younger, newer generation surgeons perhaps relying more on on-pump surgery.
Yeah, volume and outcome association is definitely one thing to look at in the future. Thank you.
Thank you very much. Do you want to introduce?
Sure. I'd like to welcome Dr. Jellink. It's going to be talking about understanding coronary bypass transit time flow curves with the help of a computer model.
Okay, so good afternoon. We created a simple model of a coronary bypass attached to the coronary artery. And the basic principle is such: we applied the arterial pressure curve to the proximal end of the graft and proximal end of the coronary. On the distal end of the coronary, we applied mean intramyocardial pressure, which we estimated simply by using 50% of left ventricular pressure. And both the coronary and graft were modeled as two resistances, proximal and distal, and compliance in between. And we know that graft compliance is very important, because if you measure the same graft proximally or distally, we get the same mean flow, but the shape of the curves is different. And this is because the graft expands and contracts along with the arterial pressure. So this bottom curve you see down here, this is not arterial pressure, this is volume of the graft. And if you take a derivative of this, we get the flow, which is just due to the pulsatility. So it's like a systolic peak, so it's positive flow in the early systole when the pressure is rising, and then it's mainly negative throughout the rest of the cycle when the graft is slowly contracting. And we know that this compliance has a profound impact on pulsatility index. So this is a simple experiment everyone can try at home. It's a Lima to LAD graft. The top row is proximal measurement, bottom row is distal measurement, so near the distal anastomosis. And while we measure, we gradually occlude with fingers at the distal anastomosis. So if you look at the proximal measurement, we see when we gradually occlude the graft, the flow goes down, but we also get these systolic peaks and high pulsatility index. So the shape of the curve changes, and we end up with this curve, which is zero flow, and this is exactly what we saw before. So filling of the graft in the early systole and emptying throughout the rest of the cycle. Now, if we do the same measurement distally at anastomosis, we see that flow goes down, but the shape of the curve does not really change. So the pulsatility index does not increase. So we can think of our proximal measurement as sum of two flow curves. So the distal one, which is actually the flow that goes into the coronary, plus the flow that goes just for the expansion and contraction of the graft. And if you have low flow going to the coronary, and this can be because of stenosis, because of competitive flow, poor runoff, whatever, you mainly get the second curve, which produces high pulsatility index. And these are a couple of examples of occluded grafts. So in our model, we tried this by increasing distal resistance on the graft, and we got the same results. So the first row is proximal measurement, and the scales are different for each curve. And you see the pulsatility index increases, the shape of the curve changes, whereas on the distal part, just the flow goes down, but the shape is the same. And some other examples, let's say bypass to the right coronary was modeled simply by reducing the mean intramyocardial pressure. This is this green one here, and we get higher flow in systole, which is typical for the grafts to the right coronary. Now, the opposite is true if you have, let's say, a patient with aortic stenosis, where you have high left ventricular pressure and also higher intramyocardial pressure, which then reduces the systolic flow. And this is a Doppler recording from an LAD, intraoperative recording from a patient with aortic stenosis. Now, then there's insufficiency, which is kind of typical for in situ arterial grafts. And this can be modeled simply by making a short time delay between the pressures to the coronary and to the graft, because we know that there's a short distance between the root and the LAD, and a bit longer distance if you go along the ascending aorta, subclavian, and then back on the memory. And if you make a small delay, we get this early systolic negative flow, which we often see clinically. Another clinical example, left subclavian stenosis, which has a typical flow, so entirely negative throughout systole and positive throughout diastole. So this here on the left is it's one of our case reports that was published many years ago. And this was the flow which we found. And the mean flow was around zero or maybe even negative. And this can easily be simulated just by decreasing and dampening the pressure that goes into the bypass graft. And we get a similar curve, so negative flow in systole, positive in diastole. So to conclude, it's a very simple model, but we were able to simulate many, let's say, clinical scenarios. And I think it helps surgeons to understand how these changes in the flow curves are generated. And it also emphasizes the importance of graft compliance, particularly its impact on pulsatility index, which is something we measure every day, but it's a metric that can easily be manipulated just by changing the location where we make our measurements. So I'll finish here and thank you.
Just keep going.
I think we should, yeah. Thank you very much. We'll move on to the next presentation. That is assessment of surgical revascularization completeness with quantitative myocardial blood flow distribution derived from CCTA in fast-track CABG trial.
Thank you.
Professor Sorois himself, thank you.
Yeah, as you could see, John Puskas is involved in that study. That's the fast-track study. So the background is that the fast-track trial was a proof of concept demonstrating that we can operate it. You see the slide? Oh no, that's what I see here is different from there. Okay, I'll look at there. There is no universal definition of complete revascularization. However, incomplete revascularization of coronary arteries after PCI of CABG has been associated with a poor prognosis. And complete revascularization is frequently self-judged by the operator. So this is an example of fast-track CABG is a proof of the concept demonstrating that we can operate patients without conventional cine angiography. Anatomic and functional non-invasive multi-slide CT were analyzed before bypass grafting that has been published in the European Heart Journal this year in May. So what you see here is the percent left ventricular myocardial flow, LV% myo, at any location in the coronary artery. This is the description of the method, and at the bottom of the slide I put all the reference. So the LV myocardium and coronary tree are extracted with deep learning algorithm, that's reference 1. Total LV and non-LV flow are computed based on LV myocardium mass, that's second reference. Coronary tree center line are classified as LV feeding or not LV feeding based on a diameter-dependent distance threshold. LV and not LV flow are distributed top-down in the LCA and RCA in proportion to downstream vascular volume at each bifurcation with a flow-to-volume scaling law down to the outlets of each tree. And finally, the percent of LV flow, LV% myo, is measured at any location. So it's a kind of theoretical percent of LV mass or flow supplied by a vessel, assuming an LT coronary tree and myocardium. So what you see here in the central part is the classic heart flow measurement of the FFRCT, right 0.8, LAD 0.5, circumflex 0.58 and 59. And then at the outside of the illustration, you see the percent distribution flow to the posterolateral, the PD, so together is 17.7%. Then you have the side branch, the small side branch, 1%, 0.7, 0.8. You end up here with 20.6%. That arrow indicates the point where the FFRCT is less than 0.8. And you see the same type of analysis in the LAD and in the circumflex. Note that the first diagonal is not involved in the process. So before surgery, you have a total LV% myo at risk of 87.2%. Now, post-bypass surgery, you see saphenous vein graft, very high implanted, with almost a normalization of the FFRCT. You see the Lima normalizing the FFRCT to 91, and the saphenous vein graft on this difficult circumflex with multiple lesions go to 0.81, but it's not normalized. So what was in red before is now in green, and as you could see, the only vessel who has not been bypassed is the obtuse marginal ear, but the residual percent, LV percent myo at risk is now 13%. This is the global result of the study with 96 patients with pre and post CTA bypass. Before the surgery, there was 70.1% with a standard deviation of 18.8% of LV percent myo. After surgery, 14% with a standard deviation of 15.3. We can make the difference between the patient with total occlusion, going from 69.5 to 10.8, and the patient with total occlusion going from 76.8 to 14%. So the percentage of ischemic myocardium in pre-procedural can be quantified on CCTA pre-CABG. The software will be commercialized in the first quarter of 2025. The CCTA post-CABG allowed the quantitative assessment of the residual ischemic myocardium. That will be a fixed numbers. This is a unique way to provide individual quantification of the revascularization completeness. Thus, before the procedure, we can identify the best anastomose site that will maximally minimize the residual ischemia and help the surgeon in identifying the vessel and the subtended myocardium that need to be revascularized. This is in a review process somewhere.
Thank you very much. I think that's really exciting because as surgeons, we're really blind to the outcomes of our operations. We always think we've done a great job, but actually seeing which target area was completely revascularized compared to which territories didn't do so well would also help educate the surgeon on where to focus their efforts and what to do better. So I think that's really exciting development to look forward to.
Yeah, sure. I mean, the intention to treat is something that the surgeon decides in advance, saying, I'm going to do this and that. And we review the literature, which is huge, of course, on complete revascularization. And you could see it go from very high number to very low numbers. So already at that time of the syntax, Frederick Moore was in trouble with his colleague surgeon because we were talking about the intention to treat, and they were looking at the residual syntax score. This is a quantified way to do it.
Can this also be applied to PCI?
Sure. Yeah, thank you.
Great, look forward to the development.
So we have next Dr. Pedinari, who's going to talk to us about national trends and results in bilateral mammary artery use.
Good morning. So as we know in this paper already for more than 10 years ago, the authors analyzed the trend use of bilateral mammary artery, and it was, as every one of us know, is quite low because it was just 3.9% with a peak of 4.5% in 2008. And this use of bilateral mammary artery was also varying in function of age, male gender, and also if the patient was operated in a university hospital or not, or if it was in an urban hospital or not. So the aim of the study was to analyze the trend of use of bilateral mammary artery in Belgium and explore the early outcome compared to the single mammary artery in primary CABG surgery. And we used the recent data obtained from the outcome project of the Belgian Association of Cardiothoracic Surgery. So we extracted non-emergent primary coronary artery bypass graft patient from Belgian National Cardiac Surgery Database with the primary endpoint mortality up to 1 year, and secondary outcome was deep sternal wound infection, stroke, and reoperation. Here you see the list of the patients that participate at the study, and this is just the slides of the data for the year 2021, with in total, not only cabbage, in total database was 5,000 patients. And here you see the distribution of number of patients per year, so it was a collection of 2021 up to 2023, and only just a part of the last year, 2023, was inserted in the data set. And here is the central demonstration of the use of bilateral mammary artery in this population that was up to 41.9%. So it's a little bit different than other national report. The two populations differs in several characteristics as expected, because patient using bilateral mammary artery was more frequently male, they were younger, they have less NIA class 4, and so on. Important to visualize also, we present here the density plot of the use of BIMA and CIMA in function of the age. As you can see, the use of BIMA was predominantly in patients with age between 50 and 70, 75. After 75 years, the use of BIMA dropped in use and was nearly sporadic. To know, unfortunately, also that in the group of patients between 50 and 60, then still nearly 50% of them receive a single mammary artery, unfortunately. Second parameter important to the decision to use a bilateral mammary artery is the presence of diabetes as an important risk factor. And here you see that a patient with diabetes, the BIMA was using nearly 1/3 of this group. Thirdly, another important risk factor we'll consider in this decision making is the BMI. So also in case of BMI more than 30, we see that the bilateral mammary artery was still used, of course, in a very small portion than comparing patients with lower BMI. So comparing the coronary anatomy, we see that the patient in BIMA group had higher chance to have a circumflex lesion or a right coronary lesion, resulting in a higher rate of three-vessel disease, and further they have also a higher rate of main stem lesion compared to patient in CIMA group. The percent of patient presenting as urgent case was similar, and because this population was just in non-emergent case. And here you come, the mortality up to 1 year showed no significant difference between the group, and in the left part of the plot, about 200 days of follow-up, we see that the CIMA group had a little increase in mortality risk. Here you see, to give you an idea about the follow-up duration, with this density plot or the follow-up present for this patient, and you see that unfortunately the follow-up is condensed and mostly in the first 4 months of period. Secondary outcomes were similar for the most important outcome that we can measure in this population. But unfortunately, as expected, patients with BIMA grafting have the higher risk of superficial sternal wound infection and a higher rate of sternal suturing in this group of patients. So, in conclusion, we report a very high rate of use of bilateral mammary artery in our national dataset, and this rate is much higher than other national reports. Early complications were similar apart from the sternal resuturing and sternal wound problem. So, I think we can demonstrate that in our country we have quite good results and good quality of coronary surgery, but further database is increasing information also for the next year, and we hope to have more idea in the reauthorization program. I thank you for your attention.
Yeah, thank you very much. Yeah, I think we should move on to the next talk. I'd like to invite Dr. Maria Comanici to present long-term survival following multi-vessel coronary artery bypass grafting and percutaneous coronary intervention using drug-eluting stents, a 20-year propensity score matched comparison.
Thank you very much once again. Through this study, we will be reporting the long-term survival following multi-vessel CABG versus PCI using drug-eluting stents over a period of 20 years at our hospital. As a quick introduction, coronary artery disease often requires revascularization through either PCI or CABG. And although CABG has proved to provide long-term, more durable outcomes, the advancements of PCI techniques, and particularly the introduction of drug-eluting stents, have significantly provided better outcomes in those patients as well. And our aim was to evaluate and provide contemporary data. Again, it was a single-center retrospective analysis. We employed one-to-one propensity score matching. We used Kaplan-Meier curves and Cox regression, and we also did a subgroup analysis in some specific patient subpopulation. Our initial cohort was almost 14,000 patients, with most of them undergoing CABG. After propensity matching, our numbers were reduced quite significantly, but we were able to achieve matched cohorts. In terms of long-term survival, our results demonstrated a clear benefit of CABG over PCI at both 10 years and 20 years of follow-up. Further, when we analyzed the outcomes of off-pump and on-pump techniques, off-pump outperformed on-pump, but both techniques did better at long-term follow-up than PCI. In terms of predictors of long-term mortality, we demonstrated that patient-specific characteristics such as age, diabetes, renal disease, COPD, cerebrovascular disease, they were all associated with higher rates of mortality. On the other hand, CABG and also use of single, multiple, or total arterial grafting, all of these techniques were associated with better survival at a long-term follow-up when compared to PCI. We did a subgroup analysis looking at elective cases, and we also looked at patients with left main stem disease. In both of these analyses, we could see better long-term outcomes for the CABG cohort. To summarize, we demonstrated a clear long-term survival advantage of CABG over PCI. CABG consistently achieved higher survival rates at 10, 15, and 20 years, and regardless of the surgical technique. Thank you.
Yeah, I think in the interest of time, we're going to move on to the next talk.
Congratulations. I'd like to welcome Dr. O. Oh, Dr. Kim is going to do the presentation. Thank you. It's histological changes and increased endothelial nitric oxide synthase in patent saphenous vein grafts and long-term follow-up after coronary bypass surgery.
Good afternoon. I'm a cardiovascular pathologist from the Seoul National University of South Korea. And I will present our research on the histomorphological changes and increased endothelial nitric oxide synthase called eNOS expression in long-term patent vein grafts following coronary artery bypass grafting. Arterial grafts in CABG maintain long-term patency well. However, venous grafts have poor long-term patency. Using the no-touch harvesting technique improves the long-term success of vein grafts, and Dr. Suja's group found that this method preserves endocellular cells, leading to increased enos expression, which enhances graft patency. However, previous studies have only examined freshly harvested vessels during surgery. Since it is not possible to study functioning patent vessels, we examined grafts from hearts explanted for reasons unrelated to graft failure after CABG. Our goal was to investigate the histomorphological changes and enos expression in successful vein grafts. We obtained saphenous vein and IMA grafts from the heart of a total of 8 explantation patients. These samples were compared to freshly harvested SVG and IMA controls. We analyzed vessel cross-sections using elastic staining and digital imaging. Enos expression was measured in 20,000 endocellular cells by segmenting their nuclei. We used CD31 to identify capillaries and evaluate enos in the adventitial vasa vasorum. IMA grafts showed minimal intimal thickening. In contrast, SVG had significant intimal growth, smaller lumen diameter, and thicker medial layer, and developed arterial-like elastic lamines here and here. These changes confirm arterialization. However, failed vein grafts lost their elasticity and underwent aneurysmal dilatation. In SVG, intima developed fine microscopic clefts and maturation. In contrast, obstructed SVG lacked these clefts and were composed of dense collagen aggregates and lost endocellular cells. Additionally, the intima of patent SVG was positive for smooth muscle actin. However, obstructed SVGs were SME negative. This difference indicates distinct compositions between the two intimal layers. In main lumen, IMA grafts showed a significant increase in enos compared to IMA control. Similarly, patent SVG showed markedly elevated enos compared to SVG controls. In contrast, SVG obstructed lost endocellular cells in the lumen, resulting in no expression. Interestingly, successful vein grafts also demonstrated a marked increase in enos expression in the capillary endothelium of the adventitial vasa vasorum in the outer media and adventitia. In quantitative analysis, enos expression was significantly increased in vein grafts compared to vein controls in the adventitia vasa vasorum. However, obstructed SVGs showed no enos expression within the adventitial capillary endothelium. In summary, in successful vein grafts, enos expression was markedly increased not only in endocellular cells within the main lumen, but also in the endocellular cells of the adventitial vasovasorum. This suggests that the luminal vessels within the fibro-adipose tissue in the adventitia may be an important source of nitric oxide. And these findings suggest that the superior performance of the no-touch technique may be due to the preservation of abundant adventitia, which provides more capillaries that serve as a source of nitric oxide. Thank you for your attention.
Thank you. Okay, thank you very much. I'd like to invite Dr. Hristo Kirov to present the prognostic impact of prior percutaneous coronary intervention in patients undergoing coronary artery bypass grafting, systematic review and meta-analysis. Thank you.
Thank you very much, dear Chairman, ladies and gentlemen. You all know that in the recent years or in the recent decades, the PCI techniques has advanced significantly. And this has resulted in an increased number of patients undergoing PCI as our cardiological colleagues are able to treat more and more complex lesions. It is also obvious that most of the patients who present with acute coronary syndromes are treated primarily also with PCI. So the result of more and more patients having previous PCI and later requiring coronary artery bypass grafting might increase the complexity of the procedures and make bypass grafting more challenging. So our objective in this work was to assess the prognostic impact of prior PCI in patients with coronary artery disease who later underwent CABG. We did a systematic review and meta-analysis, as usual, registered prior to the starting of the project, our main points in the Prospero. It's an important step to avoid investigator-associated bias. And then we did literature search in 3 databases. We could identify 1,200 papers for the first scan, and after that retrieved 900 studies, of which only 19 were selected and fulfilled our inclusion and exclusion criteria. In those studies, there were 116,000 patients, a significant number, and here is our primary result, which was perioperative mortality outcome. And probably, as we could suggest, there was a significant advantage in perioperative mortality for primary CABG. But however, after we extracted and reconstructed the individual patients' data, there was a more of a surprising finding here. Also, the hazard ratio for perioperative mortality of 1.16. But here you see the reconstructed Kaplan-Meier curve, and as you can see, approximately after 3 years, the survival curves cross, and the patients who have prior PCI do not have any survival disadvantage anymore, which was to us more or less surprising. And as the proportional hazard assumptions were violated, we performed a landmark analysis where you can clearly see in the first, here on the left-hand side, is the comparison between patients who had prior PCI and those with primary CABG in the first 3 years. There was no significant difference in the survival, and after 3 years, there was a slight but significant difference in the survival favoring patients with prior PCI. Concerning the other secondary endpoints, we assessed myocardial infarctions, neurological events, bleeding, acute renal failure, and length of stay. There was no significant difference between the groups that we assessed. So, in conclusion, I would say that when compared with patients who underwent CABG as primary treatment of coronary artery disease, prior PCI is associated with a higher perioperative mortality for patients undergoing CABG, but this increase in the perioperative risk does not correlate with a decrease in the long-term survival of those patients. For your attention.
Thank you. Do we have time for questions?
I'm afraid we don't.
Okay.
Yes.
Okay.
Thank you.
Thank you very much.
Excellent presentation.
So we'll move on. Dr. Feng is going to talk to us clinical outcomes after coronary endarterectomy combined with coronary artery bypass grafting and diffuse coronary disease patients, a single center experience.
Oh, thank you. Actually, that topic is at the next room.
Oh, I was on the wrong one.
There's something wrong. Today my topic is the impact of coronary endarterectomy on the graft patency in diffuse coronary artery disease patients. And this is an updated analysis. I have nothing to disclose. Coronary endarterectomy is an old tool for revascularization of coronary lesions, which is always used in combination with CABG surgery. Yet, limited angiographic evidences exist. We reviewed existing literatures and performed a meta-analysis. The results showed that graft patency was significantly lower after coronary endarterectomy as compared to isolated CABG. To further investigation, we collected angiographic test results in a cohort of over 15 years at our center. Among the patients who underwent coronary endarterectomy, 266 patients provided follow-up coronary computed tomography angiography or coronary angiography results, including 281 CE targets. Most of the patients underwent coronary endarterectomy on the left anterior descending or right coronary artery. The mean age was 59 years, and 35.7% of them had a history of myocardial infarction. The perioperative occurrence of myocardial infarction was 5.3%. During a median follow-up of more than 6 months, the occlusion rate for coronary endarterectomy targets were 10.2% for LAD and more than 20% for RCA. Let's look at some detailed information. To further investigate the graft failure outcome, we compared the results of coronary endarterectomy targets and non-endarterectomy targets. We can find here that the occlusion rate of the coronary endarterectomy were higher for LAD, RCA, and LCX. And in total, the occlusion rate is also higher. The possible reasons for the low graft patency outcome might be as follows. First of all, the coronary lesion in endarterectomy targets is more severe. Meanwhile, different from that isolated CABG, coronary endarterectomy can cause the exposure of subendothelial tissue to the bloodstream, causing the activation of coagulation cascade, which might potentially increase the risk of thrombus formation. Therefore, antithrombotic therapy after CE might be different from isolated CABG. However, antithrombotic therapy is not consistent yet. Some might use antiplatelet therapy only, while others believe anticoagulation combined with antiplatelet therapy might be better. Among the more than 200 patients from our center, the postoperative antithrombotic treatment was also inconsistent. So in these patients, is anticoagulation necessary? And to answer this question, we have been performing a randomized control trial from last year. This study recruits patients undergoing coronary endarterectomy. After screening for eligibility, patients will be randomized into DAPT-only group and DAPT with warfarin group. All of the patients will receive coronary computed tomography at follow-up, and the CE-targeted graft patency will be compared. Other factors might also have influenced the graft patency outcome, such as patients underwent angiographic test can sometimes be more likely to have symptoms. So in conclusion, among patients undergoing coronary endarterectomy with CABG surgery for diffuse coronary artery disease, occlusion rate of CE-targeted grafts might be higher than non-endarterectomy targets. Further high-quality research is needed. Thank you.
Excellent.
Thank you very much. I'm sorry that we don't have time for questions. These are very interesting presentations. I'd like to invite Dr. Omar Mejia to talk about the impact of coronary artery bypass grafting on women's frailty 1 year after follow-up, 1 year of follow-up fragile trial.
Good afternoon. Thank you for invitation, for approving our abstract. Well, which came first, the frailty of the heart disease? This is difficult to determine whether frailty or cardiovascular disease comes first because two conditions have a bidirectional relationship. We have two environment because the two conditions start in similar conditions, cellular problems and physiological drivers of frailty and cardiovascular disease, and after both have a lot of problems. Objective is to evaluate the impact of CAPG on patient frailty criteria and compare between women and men. We were able to achieve 272 patients in aged 60 years and older underwent CAPG from the fragility trial, it's a sub-analysis. The FRIES frailty criteria, classification in pre-frail, frail, and non-frail patients. The follow-up was conducted in person 1 year after discharge. The 5 components of the frailty criteria were compared between the groups. All participants signed the informed consent form. This is our trial, the Brazilian multi-center randomized trial, the 6 main CAPG centers in Brazil. It is a study design. Inclusion criteria is 272 patients. We have 60 years old or older, 2 or more frailty elements. Intervention is on-off pump. It is elements, weight loss, physical activity level, is gait speed, is grip strength, and self-reported fatigue. We are able to achieve 88 women and 184 men. This is the all elements improve after 1 year CAPG, but it's not good for grip strength for men and for women. It's not good, it's the only element. After 1 year, we have improved in men and women. It's a significant improve. We reduce frailty conditions in both. In robust patients appeared in between in both groups. But women, when you compare men and women before CAPG, not different, but we compared men when women is different, twice more robust in men than in women. Sorry. Is twice more robust in men than in women. In conclusion, CAPG significantly reduces frailty in both men and women. The surgery improved physical activity levels, walking speed, and fatigue, with men showing particularly pronounced benefits compared to women. Thank you very much.
Thank you. It's everywhere.
Thank you. Last but not least, Dr. Saja is going to talk to us about closing the gender gap in coronary artery bypass graft surgery outcomes, progress, and challenges. Thank you.
I thank the organizers for the opportunity, and I have no disclosures for this presentation. I will be presenting on the gender gap in coronary artery bypass surgery outcomes. Coronary artery disease is the most common cause of death worldwide, and the coronary artery bypass surgery remains the most effective mode of revascularization for those with severe and extensive coronary artery disease. There are fundamental differences between males and females in the incidence and response of the bodies to various diseases, more so conditions related to cardiovascular health, particularly coronary artery disease. And also there's a lot of studies published in the past saying that the female patients are at higher risk for coronary artery bypass surgery outcomes. The objective of our study is to assess the gender differences in the early postoperative outcomes following coronary artery bypass surgery. It is a retrospective observational study. The study was conducted on the patients operated between February 2000 through December 2022. Total number of CABG patients we operated was 16,000, and female patients were 2,200, comprising of 13.6%. And we did the propensity matching was employed to create 1,956 well-matched pairs. The primary outcome was composite of 30-day mortality, non-fatal MI, non-fatal CVA, and requirement for renal replacement therapy. The secondary outcomes are postoperative myocardial infarction, requirement IABP support, postoperative atrial fibrillation, deep sternal wound infection, and the postoperative hospital stay. Coming to the patient demographics, before matching, the females are older than the males, and hypertension was more common in females and as well as diabetes. But dyslipidemia in our patients, the males have got more dyslipidemia, more number than this thing, and which did not appear after matching. However, the preoperative peripheral vascular disease, preoperative history of CVA, and preoperative chronic kidney disease were much more common in females, which persisted after matching. Coming to the procedural characteristics, though emergency surgery was done in 2.4% of all females, whereas it was done in only 1.4%, which is statistically significant, though it is clinically not relevant. And the number of female patients is high. Double vessel disease is more common in females coming for surgery, whereas the triple vessel disease is more common in males who presented for surgery, which persisted after matching, and it is statistically significant. The on-pump and off-pump surgery, we have done equal frequency, around 50-51% in both males and female patients. But the number of grafts, females received 3 or fewer grafts per patient, whereas men has received more than 3 grafts per patient, which is statistically significant. The primary outcome is a composite of 30-day mortality, postoperative MI, CVA, and requirement for renal replacement therapy. It happened 5.1% in male and 4.2% in females, which doesn't reach statistical significance. The secondary outcomes, particularly the need for IABP, postoperative atrial fibrillation, deep sternal wound infection, length of postoperative stay, there was no statistically significant difference between men and women in our patient cohort. The components of composite outcome, 30-day mortality, postoperative CVA, and postoperative acute kidney injury requiring renal replacement therapy, there was no difference between both genders. However, the postoperative incidence of postoperative MI is more common, which is statistically significant in men in our series. To conclude, there is no statistically significant difference in early postoperative outcomes between men and women in our cohort of patients, except the lower incidence of postoperative MI in the female patient. Our results are in contrast with most of the published data in the Caucasian population, European and the North American population. But probably the reason for this would be because the Indian male are at higher risk than the European male to undergo coronary artery bypass surgery. So that bridges the gap between men and women who operate in Indian population. That's the only explanation we could offer. And several times I was put this question after the presentation. Thank you.
Thank you very much. I just have one comment. There is one other possible explanation, because you're presenting data from a single center, from clearly a very experienced surgeon, whereas the data that are analyzed across the country, nationwide data on STS database or UK databases, unfortunately have a huge spectrum of ability of the operating surgeon, as Professor Sorois was referring to. There are differences, and I think in national databases you might be seeing that difference
Yeah,
coming
probably
out
this
in
is
the
a-
sicker population, in the women patients. But you're also right that male patients can be, in Asian male, Indian male patients, can be a higher risk cohort for this surgery. Thank you.
Thank you. Thank you.
Thank you for an excellent session, and well done, everybody. Good job. And thank you for staying in this room and other more exciting things going on next door.
Thanks everyone, really. Sorry that we couldn't have the discussion we always want. We are always running late. This
Yes.
is always something we can do better, but so many good abstract. Really thank you everyone for presenting it. Thank you.